Good afternoon. April is Bowel Cancer Awareness Month, and today we have Dr. Ed Seward, one of our gastroenterologists, here to answer some questions and concerns that you may have about bowel cancer. Now, first of all, before I start, I must just say congratulations. Ed ran the marathon yesterday in aid of Bowel Cancer UK. Do you just want to quickly just say a little bit about that?
Gosh, it was hot. It was a lot of hard work, but I got a time of 3 hours 50, which I'm pleased with. And the support was amazing, got to say. The people who line the streets really keep you going. So it was great, and great to run for such a good charity. They do a lot of work supporting diagnosis of bowel cancer and taking various sort of policy ideas forward, so they're terrific. So
charities. It was worth the blood, sweat and tears, was it?
Yes. Yeah.
If you could just say a little bit about your role here
Sure.
at UCLH. So as I said, you're a gastroenterologist. What does your job entail?
Yeah, so a gastroenterologist means I'm a bowel and tummy doctor, and like most doctors you specialise in a particular area, and my area of specialty is colonoscopy, which involves putting a camera inside your bottom and around your large bowel. And so the emphasis of my job really is diagnosing bowel cancer early, and then the precancerous stage of bowel cancer, which are polyps, removing large polyps.
Most people, I would reckon, who've tuned in today probably are here because, well, either they've got symptoms or there's a real reason why they're concerned. I mean, if someone's watching, what are the symptoms that you need to be aware of, perhaps?
So there's a handful of them. I think what I always say to my patients is you listen to your body, and if things change, then that's probably a sign to you that you need to pick up on that and let somebody know. Because I think, particularly in the UK, nobody likes talking about poo or bowels or toilet stuff, and there's a lot of reluctance there.
Yes.
And really a lot of my job is trying to overcome that reluctance and encouraging people to sit up and take note. So it's bleeding from your bottom, it's a change in your bowel habit, particularly to if you're passing looser poo than normal. If you're anemic on a blood test, and the symptoms of anemia are things like tiredness, or you're being more readily fatigued than normal. If you're losing weight, or if you have a sensation of a lump either in your belly or around your bottom. The problem with bowel cancer is that there are tons of conditions which are totally benign and nothing to worry about that cause those symptoms, and that's always the difficulty we have, is in encouraging people to take the symptoms seriously, because people might see a bit of bleeding from their bottom and then just assume it's hemorrhoids, just assume it's piles.
Right.
And actually that can be a sign of cancer.
It's quite a common cancer, isn't it?
It is common. So in the UK it's the 4th commonest cancer, but most significantly it's the 2nd commonest cause of cancer death. And the reason for that is it often presents late. Bowel cancer is really easy to cure so long as you catch it early, but until you have the tests or until you see a medical professional and get yourself checked out, you won't know.
Apart from, obviously, as you say, if you have the symptoms, go to your GP.
Yeah.
How important is other screening processes? How can people be screened for it before they get symptoms?
Okay, so this is where there's a bit of difference between England and Wales and Scotland. But in England and Wales, what happens is that when you turn 60, you'll be contacted by, it's called the Bowel Cancer Screening Programme. And they will ask you to do a test on your poo, and that test is looking for the presence of blood, and if that test comes back as being positive, then you'll be offered a bowel investigation, and that would normally be a colonoscopy, so that's a camera examination of your lower bowel, and that will occur. They'll ask you to test your poo every 2 years up until you're 75, and that's when the screening programme finishes.
What do many people fill in that kit and send it off?
Not as many as I would like.
How many?
So I think the average participation rate is about 58%.
So why the reluctance? Why?
Well, I think there is it's understandable. First of all, there's the prospect of doing a test on your poo, and there aren't many of us that like guddling around inside the toilet bowl, taking a bit of poo on a cardboard stick and smearing it onto a test card. But it's like many things in life, you've just got to do it, because what we've seen from the bowel cancer screening programme is that people who don't have symptoms, they engage in the bowel cancer screening programme and they go on and have a camera test. Even if we find cancer at that point, which is obviously in many respects the worst thing to hear, but the good news is that our chances of catching the bowel cancer early are very high, much higher than if you present with symptoms.
So it's really not the time to be squeamish at all, is it? I mean,
really
you just have to do it.
And survival cure rates for early bowel cancer approach 100%. So you've got a brilliant chance of having treatment and being cured of bowel cancer if you're diagnosed through the bowel cancer screening programme.
So when I've been talking to friends about, sort of mentioning about colonoscopies,
yes.
and you've just described it, and it doesn't sound very pleasant, and I wondered if this might put people off. But how can you reassure people that actually,
Well, what I would say, hand on heart, and nobody ever believes me when I say this to them when they've not had a colonoscopy, but hand on heart, the worst bit of doing a colonoscopy is taking the bowel prep and starving yourself, because you can imagine if we just put a camera inside your bottom, there's poo everywhere and you can't see anything. So we have to clean you out with very strong laxatives, and you have to fast, so you're just taking fluids for 24 hours prior to the test. But once you've done, the actual procedure takes about half an hour. It can be uncomfortable on the corners, but we can put a tiny little needle into your arm, and we can give you an injection of a sedative and a painkiller, and that will relax you and make you feel comfortable. And so actually the procedure itself is not that bad, I promise. And most people sail through it. Mostly it's really straightforward. And actually, most people say, that was actually quite interesting. They're watching the screen as we're doing.
Oh, they watch it, do they?
Oh,
you
yeah,
can watch it. Oh, right.
Absolutely.
Do you get a video afterwards?
Not just yet, I'm afraid. But they feel very engaged with the colonoscopy. They're there, they're watching what's going on, and they feel like they're participating in their treatment. And particularly if we find polyps and we have to remove them, removing a polyp isn't painful at all. The bowel's wired up differently from the way your skin is, so you don't feel the polyp being removed. And so actually it's a very straightforward, calm, measured environment. We're chatting to the patient all the time.
And you must do quite a few at UCLH, I would have thought.
No, absolutely. I mean, we've got a big endoscopy unit. We've got 6 or 7 rooms running pretty much continuously. So there's a lot of endoscopy activity going on, and that's reflected across the country. And the good news is that endoscopy activity is increasing across the UK. But the more endoscopy that we do, the more colonoscopy that we can do. Hopefully that means that we'll be catching people earlier, so they don't have to face operations or major treatments. If we can catch it early, then that's
so early detection's the key, isn't it?
Number one.
Tell me about this new research trial. Is it QFIT?
QFIT.
Yeah.
So what we're doing across London at the moment is what we call the QFIT trial, and QFIT stands for it's a complicated acronym, but it's quantitative fecal immunochemical test, and all that means is it's a slightly fancy test looking for the presence of blood in the stool.
Right, okay.
And it replaces the slightly more old-fashioned test that's used currently. And we're basing our work on a big study that was done in Scotland, where they took about 750 patients. You do not have bowel cancer, well then that's great.
Brilliant, isn't it? So what stage is that research trial at then?
So we've just opened.
Just at UCLH or other
No,
centres?
so it's across, it's called the London Vanguard region. Vanguards are organisations that are set up by the NHS to try out new ways of treating people or investigating people or managing chronic conditions. And so this is what we're doing for the London Vanguard, the bit that I'm involved with. And so it's basically we're going to get 2,000 patients over the whole of North London and out to Essex. And we're going to see if we can replicate the data that they had in Scotland. Because the exciting thing about the Scottish study was that, you know, not only did they find that this was a brilliant test of on cancer, because of course they're not, all they're doing is they're looking at, say, 1,000 people who've got bowel cancer and comparing them with 1,000 people who haven't,
Yes, yeah.
and trying to see
It's
if
quite
there's any
different,
difference.
yeah.
But red meat, and particularly processed meat, so things like sausages or bacon or ham, and it's, if you can moderate the intake of those products,
Yes.
then you can reduce your risk of getting bowel cancer.
Right.
You don't have to go crazy. You don't have to cut it out of your diet completely. But the idea is it's just being sensible.
Moderation.
So you might have it once or twice a week rather than 5 times a week.
Yeah, I see. But with diabetes, there's not a direct link. It sounds like okay.
Yeah.
Someone else has this is very interesting as well. This question via email. Somebody's dad has died of bowel cancer. And they're obviously worried about the genetics. Does it run in families, and is she more likely to get it? I mean, is that a risk? Or?
So the biggest risk factor for development of bowel cancer is actually age. So all those symptoms I said at the beginning of this program, you're looking at in this at 50 to 55. Were diagnosed.
How long does it take for bowel cancer to sort of come on? I mean, is it something that you have in your body and it takes years?
It does take
sometimes
years.
Prostate cancer.
No, that's exactly right. Most people's perception of it is that it pops up, you know, over months or years, but actually, bowel cancer, it goes from normal tissue to a polyp stage before it becomes cancerous, and the polyp stage may last 10, 15 years. Or even longer in some cases. So it's we've got a long old period of time to intervene, and if we whip that polyp off before it turns into cancer, then that's a problem saved later on. So never panic. You know, there's nothing has to be done tomorrow, sort of thing. But if she's anxious, then sure, have a word with your GP. You know, it won't do any harm.
Okay. If the tests show that you do have bowel cancer, what treatment are you looking at then?
Generally, we'll be talking about surgery, but really what will happen if we diagnosed a cancer on somebody today, then the first thing we would do is to arrange for scans, because like most cancers, you need to know whether the cancer is confined to that organ, so is it just within the bowel, or has it spread beyond? So we would generally do a CT scan or maybe an MRI scan as well, and that will give us important information about what's going on in the rest of the body. And if the cancer's localised to the bowel, to the colon, then that's good news, because that means we've caught it early, hopefully, and usually we'd expect to get a cure just by surgical removal. And I should say that bowel surgery doesn't automatically mean a bag. Lots of people are really anxious about the thought of having a colostomy. Again, it very much depends on where the cancer is inside the bowel, but it's not inevitable by any means. And we're getting better and better at avoiding that sort of issue.
And if you've had surgery, what the chances are that it will return?
Again, it very much depends on the stage.
Email. Someone says that they've recently been diagnosed with Crohn's disease. I'm really worried about bowel cancer. Is my Crohn's likely to develop into bowel cancer? Is there
so there is a link. It very much depends on which part of the bowel the Crohn's disease is affecting. So Crohn's disease in the small bowel, there's two bits to your bowel. There's a small bowel and your large bowel. Your small bowel is very well behaved. It doesn't generate cancer. It's very rare to generate cancer. And small bowel Crohn's disease doesn't put you at any increased risk of cancer. And that's where most people who have Crohn's disease have inflammation. If there's inflammation in the colon, in the large bowel, then yes, there is an increased risk. And generally what we say is that risk begins to pick up I was a doctor for 2 years before a medical student told me that actually we don't say that anymore. You know, things have moved on. So I think Always. I mean, in my field, in the field of polyp detection and polyp removal, literally every month there are papers coming out. So no, I really think, and that all filters through to everyday practice.
Yes.
So I think I certainly want to tell people that there are novel treatments and novel ways of managing things that are coming out in the NHS constantly. So it's a very exciting field to be involved with, really.
Yes. You say it's an exciting field. Why did you come into this field?
Well, I do get asked that question.
Intrigued. I'm always intrigued as to how specialists find themselves in one.
A good nursing doctor as a doctor can. And then outside that, we have clinical nurse specialists who feed in, and they're the sort of human face of the hospital. I think
humans.
Well, I think when you're a patient, and particularly when you're outside the hospital and you're trying to get information, it can be difficult.
Yeah, we've got some lovely clinical nurse specialists.
I agree. They're fantastic,
yeah.
And they're there to translate what doctors say, because doctors speak a lot of gobbledygook sometimes, and it's just having somebody that people can speak to and relate to, which I think is really important.
Are they available at the end of a line? I mean,
very much so. I mean, as much as they can.
As much as they can, of course.
Yeah, it's difficult, but they are. For you. As I say, I won't say we make it fun, but we
won't
do.
go that far, but yeah.
No, but it is informal, and we'll chat to you, and then we'll tell you the results there and then. So there's no hanging around for results.
That's important as well,
isn't it?
Yes.
Yeah, you don't go home wondering. If God forbid if there was cancer there, then we will tell you, look, it is cancer there.
Let's get moving on this.
We're going to get the scan done, and at least, even if you hear that word, at least we've got a diagnosis, and then with a diagnosis we can get a cure, and bowel cancer is curable. So don't turn your face to the wall, don't think that's the end. We need to be positive, because we know that we can cure cancer, but we can only cure it if we know it's there. So do see your GP. Say, well, it's only there every now and then, surely that's okay. I can't give you that reassurance until I've had a look. So
the person who sent that should really go to their GP.
That would be my recommendation, because I don't know how else you can give reassurance until you have a look, to be honest.
Right,
yeah.
Okay. I don't think there's any more questions, apart from someone said, "Go Edward," and thank you, which I think is
that's
nice,
very
isn't
kind.
it?
Thank you.
It's very kind.
I got plenty of that yesterday.
Yes. So I think really the main thing is it's treatable.
Yes.
In most cases, if caught early, so it's important that if you experience any symptoms that aren't normal, go and see your GP, and if you're eligible for screening, take that test. If you get
must.